get started here, just go through a physical examination of the knee PowerPoint. I have no disclosures, and my mentor is Dr. LaPrade, and he had a lot of videos that we're going to use. So, getting a good history is certainly very important, talking about how they injured themselves. Was it a non-contact injury, usually ligament, or more contact, which anything's possible. Mechanical symptoms, what makes it worse? Is it going up and down steps, which is classic for anterior knee pain? Is it deep squats, which can be anterior knee pain, can be a meniscus issue? Those locking, catching, clicking type things often can be patellar instability. Can they be a chondral defect, a loose body, meniscus problem? Those are all things that I look for. This is an interesting video of a really bad knee injury, but unfortunately it's not going to play. So, again, my first thing is to talk to the patient, try to figure out what are their goals, what do they want to get back to. And that's true for the high school kid that wants to get back to sports, as well as the 65-year-old who wants to be active and wants to play weekend sports or be recreational athlete with golf. I find patients tend to like when I ask that, like, what are your goals? Because I don't think many doctors and many providers ask that, so I try to phrase it like that because I think they are a little taken aback, and then they actually say, okay, like, this is what I want to get back towards. So I try to use that phrase. I ask every patient, what's the hardest thing for you to do with this injury? And that really gets me down to what's the one thing that's driving them to come in? What is the thing that's really bringing them to me? So I also will use that phrase. Oftentimes they'll describe instability not as my knee feels unstable, but it's I can't trust it, it just feels wrong, I just feel like I can't do the things I normally want to do. Very rarely does someone say my knee feels wobbly or cause something like that. Certainly location of pain, mechanical symptoms, is there something like a flap of tissue, a chondral defect, loose body that's flipping in and out that is the reason for them having symptoms. An acute injury is a totally different story than a chronic injury. So if they have a big swollen knee that is ecchymotic and has signs of an acute recent traumatic injury, that's a different algorithm than somebody who presents with 2 years of medial-sided knee pain. A lot of times that locked knee is a very important thing to identify. So people who can't fully extend or can't fully flex, that may be a flipped bucket. And those are things that we don't necessarily want to push through until we image them and understand exactly what's going on structurally. Some people talk about injecting a bucketed knee with lidocaine to try to get it to reduce. I've never had very good luck with that, and I think a lot of times if you end up completing the edges of a bucket into a more unstable tear, it's much harder to fix and fix well. So I very rarely will do that. I usually just take them and get them fixed. Again, chronic injuries, that can be other lesions. The whole reason we're fixing ligament instabilities prevent that next cartilage and meniscus injury. So if it is a chronic ACL, I'm looking for that, posterior horn meniscus tear. I'm looking for other chondral defects that may have been going on because the ligament injury is there. So first thing is, to observe their knee, evaluate for, deformities. Do they have prior surgery? Do they have a big effusion? Signs of an infection? Things that are just very basic. And these are all things you guys do without even thinking about it. What does their skin look like? Do they have an obvious deformity? Certainly more of the joint replacement population may have very obvious, especially valgus deformity with very bad lateral compartment arthritis. Over time, they can be very impressive, frankly, that they have these really deformed knees, and those are all just from years of wear and tear of their arthritis. If they have very varus or valgus deformities from a chronic standpoint, those are also important in the young population, because if you're looking at reconstructing ACL and they are in varus, and they may have a missed posterolateral corner injury, they may have other things that can place them at risk for failure of the ligament reconstruction. So in general, I try to compare to the other side. I try to start with observation and then work systematically through them. I try to do this, and certainly it's a goal to do the same thing every time when I'm evaluating a patient. That way you don't miss something. I try to have them do the most I can do functional testing. So a lot of times I'll do a single leg squat in the office, and that's something that really can identify weakness. And I know you guys do a lot of that, but especially as you're rehabbing somebody, I look at that. And then I save what's bothering them, or the thing that's the first thing that pops into my head when I hear their story. I usually save that for last. So if I'm really thinking ACL, I'm not going right to the Lockman, because they usually just get very tensed up with that. So I'll usually save that for at the end, just check some gentle motion, patellar instability, collateral ligaments, and then kind of work to that at the end. So, working through the history, certainly patellofemoral joint, you'll often hear I have this anterior knee pain. They can describe some giving way or that pseudo-laxity of patients who have patellar maltracking. And that's an important thing to differentiate between patellar maltracking or just pain in the front of their knee. Often worse with deep squatting. Again, many of these patients have had a lot of different treatments, and identifying what's worked, what hasn't, and why they're having pain, like the one we just talked about. If his problem is muscle mass and can't actually keep his kneecap stable, centered, and tracking well, that's nothing I can fix with surgery. I can't add more bulk to his quad. That's something that really needs time and strength training to build that back up. But we have to do that in a way that isn't causing pain that's going to kind of perpetuate this cycle for him. So first thing I'll do is I'll just palpate the patellofemoral joint. I'll palpate both kind of rock up and down and really try to feel for crepitus. And you guys probably have felt that for patients who have a catch, a click, or just an obvious problem with their cartilage. And I'll also go medial to lateral. Someone who has that pop in the knee, and it's like the classic thing where it's an obvious, everyone's assuming ACL, you really have to look for that patellar instability, because sometimes it will be a patellar dislocation that you're picking up, not an ACL. Whether or not they have kind of apprehension to that is important. If they really, and somebody who has patellar instability will hate you translating the patellar laterally. They're going to tense up, they're going to really bother that. And the other thing I'll do is I'll put my thumb next to their knee and I'll have them bend and straighten. And if their pain gets better with good that would be medial pressure, then I'm thinking that lateral instability is really their problem. And they do great with a stability surgery to give them an MPFL or address their bony deformities if they need an osteotomy. So that's where I start, usually with an evaluation. And again, to look more at the cartilage, that's more of the front back, and I'll tend to rock patients' cartilage near kneecaps to do that. And I find doing that at different flexion angles will also be a little trick to try to find, because a lot of times if they're high in their trochlea, you may miss something that's deeper in their flexion arc that only if you put them at 30 degrees will you actually engage. It's a little harder for them to relax as they get a little deeper into flexion, but if you can get a patient to do that, many times you'll pick up cartilage problems a little deeper in their trochlea that you may miss when they're in full extension. So that's just a little trick when I try to examine them. Scarring in their fat pad, it's a little harder to pick that up, but certainly if they have less mobility, that's part of the reason that it can be is fat pad fibrosis and scarring. Again, have to really relax that patient, and this is just kind of how we'll do that, really front to back, bend their knee, work on medial and lateral stability. And one of the things I'll look for patellar instability is when do they actually engage their trochlea. A lot of times people who have very high riding patellas, patella alta, don't actually engage the bony groove of their trochlea until about 40, 50, even 60 degrees of flexion. That's a problem because if you're trying to fix their instability in full extension, most people engage around 20 or 30 degrees. So then you have to think about that when I'm tightening them and where I'm actually tightening them to keep them centered. So that's something that I'll try to evaluate for instability patients. Patellar tendinopathy is mostly inferior pole pain. I find that when they're in full extension, and again, this is this kid I saw today, their pain actually has more pain than when they do when they flex up. So that's something that I'll think more about their patellar tendon being a source of their pain. If when I flex them up, they're like that inferior pole doesn't bother them, but it does in full extension. When I was in Colorado, like patients hiking down at the end of a hike, this was classic for patellofemoral problems. They just got weak, their mechanics were off, and their quad strength wasn't enough to allow them to complete that without discomfort. So again, this is more maltracking versus pain, but hopefully this video will work. Maybe not. But this is a J sign, which I think you guys have probably seen, where you have a pretty obvious lateral tracking that does engage the groove and pop back in as you go into flexion. Certainly, again, apprehension tests, those are all things to look for when you're looking at instability. So you guys get a ton of anterior knee pain. I'm sure it's super common. Instability in that setting is a little different, and treating that is, I think, something that you may pick up that sometimes maybe it isn't picked up for you. You can say, look, I see a J sign, I see that you have a lot of apprehension with lateral translation. Those are things that working on, a patellar sleeve or really addressing VMO strengthening, all of that, as you know, is a big part of that, not just your general anterior knee pain that you get on a script that shows up in your office. So, you guys have any tricks, anything about instability or things you really try to focus on? No. Okay. It's less common now, but medial patellar subluxation or instability was a problem when we were doing a lot more lateral releases. I'm sure you guys saw a lot of these patients more 10, 15 years ago, but you can create the opposite problem by trying to fix that, and that's why we don't do this anymore, is that you had this patient who, if you watch, and I know this is a little slow, but if you watch, you can see you can medially, that's not laterally, medially sublux that patella, and then you can see their trochlea there right under the thumb. And that's the opposite problem. Now you have to go back and actually reconstruct the thing that you did a lateral release on. So it's a challenge, and you'll see a couple people who have had a history of a lateral release, and that's the opposite if you're doing taping and things like that. Are you guys doing a lot of McConnell taping or anything?
I do a lot of KT taping.
Yeah.
The only McConnell tape I typically do is for patella dragging.
Okay. So this would be the opposite, and this is where if you get this, you have to really make sure the person writing it said, okay, they really want you to reverse tape it, which is a pretty uncommon but certainly real situation if you have that problem. Looking at hamstring tightness certainly is a huge effect on their anterior knee pain. It's most adolescent, especially males, and males, college and going on, are just tight their hamstrings, and working on that is a huge part of getting their anterior knee pain better. Certainly you can have, bursitis from that, but that's something that you guys know and is part of your daily explanation, I'm sure. So then as we look to the actual tibiofemoral joint, again, I'll try to save that area that seems to bother them or that pops into my mind first. I'll try to save that for the last. I think a lot of this is all about anatomy, and that's how I examine them as I start working through the anatomic structures and how I'm going to evaluate them. And I usually start with simple motion. So one of the things that I think maybe isn't taught a lot is hyperextension and how that affects your both injury risk as well as what I'm looking for when I try to evaluate for injured structures. If you have this much hyperextension on the right knee compared to the left, usually that means it's not just an ACL tear. Usually that means there's a posterolateral cord injury or some other some other collateral injury that's affecting their hyperextension. So, this is a recurvatum test or a heel height test. So I'll dictate that, and this is where I think there's a little difference between probably physical therapy and how many orthopedic surgeons will dictate motion, but I'll dictate 1 centimeter, 2 centimeters, up to 3 or 4 centimeters of heel height as my extension degree, and then I'll go to 140 or however much flexion that I think it is. So, and I know this is probably debated whether it's negative or positive, and I don't know if there's a right answer to that, but this is how I will describe in my notes extension and how much or how little they have. So if they have a larger amount of hyperextension, then that's something that I'll be more concerned about not missing another injury, because usually that can be there. And again, it's all based on, some people are very lax, and this is one of the tests for a Baton score, is can they hyperextend their knee? Is that something that is part of their overall laxity? And then obviously flexion, that's, I think, different depending on who you are, your tightness, and the numbers that you're going to give that, but obviously comparing that to normal is very important. And the things is a number of things. Certainly classically a meniscus tear, an OCD lesion, deeper in flexion causes flexion deficits, but all of those are possibility to limit your flexion. And as you start talking about problems of the anterior translation or the ACL, that's the most common thing we see, and certainly from a ligament instability, something you guys are seeing a ton of. Hearing that history of, I went to go plant, I felt the pop, I tried to pivot or turn quickly, it's a classic story, and it's not something that you really want to pick up for. Typically, they're non-contact injuries. It's a very common thing in our athletic population. And frankly, from an injury prevention standpoint, I think it's part of the holy grail of how we're trying to limit the amount of these that we're doing is identifying in these pre-participation physicals people that are at risk for this, people who have they're landing in valgus, they're landing with full extension, things that we're trying to identify ahead of time so we're not having athletes who have this injury. I don't think we're great at that yet. I still think there's a long way to go. Your anterior cruciate ligament is really the main stabilizer to anterior translation. The Lockman examination is really the best way to test for that. I'll usually have the patient, you have to have them relaxed. I'll usually have them just kind of roll their leg out, and it's about 20 or 30 degrees. My up hand, depending on which leg it is, will be behind their femur. My down hand will be kind of cradling their tibia. And I'll just gently, it is not a very dramatic thing, but I'll just gently kind of feel for initial motion, feel for an endpoint, and see how much laxity that they have. If you feel it, it should be a rope. It should be a very obvious endpoint. And the best time is right when it happens. So like if something happens on a football field, you'll get the best exam you can right then. You can kind of put for somebody who has a really big leg, like I have big hands and sometimes I still can't get around it, then the other way is I'll kind of put their knee, I'll put my hand underneath of it, and sometimes use two legs or two hands to try to evaluate that, but it's hard. Anybody who says they can get a great Lockman exam on a really, really big leg, I think is lying to you, because it's hard, and it's something you have to really try to work at to get a good position and get them to relax. But that's certainly the mainstay of assessing your ACL. And remember, your ACL has two bundles, and those two bundles affect not only translation but also rotation as well. So in the 90s, we were doing a lot of very vertical ACLs, and they had great Lockman exams, but they all still had the sequelae of ACL instability, future cartilage and meniscus problems. And the reason is because we weren't controlling their rotatory instability. So instead of placing the tunnel directly at 11 or 12 o'clock, we're trying to put it lower on the wall now so that we're both controlling anterior translation as well as limiting their rotatory instability. Those are people who you may see who have a great Lockman, but if they pivot, which is the test for that rotation, their ACL is not functioning. And so that pivot shift is an important thing to look at, and we'll get to that. So, just from an anatomy standpoint, your ACL, if we look here, is really two bundles, anterior medial and posterior lateral. So they're named in relation to where they insert on the tibia. Certainly, you can see that as you follow your anterior medial bundle up, it inserts higher in the intercondylar notch, and it inserts very posterior. The posterior lateral bundle is the lower bundle, and if you look, it does go especially in flexion, it inserts very low on the wall. So that's really where we're trying to recreate that anatomy. I guess I have to do this with a play. When we're trying to reconstruct this type of an injury. Technical difficulties here in the video. And again, this is a good example of a Lockman, so this video is playing, I don't know why. But you can see that translation, it's not pulling that person's tibia through the roof, right? But it's that increased motion, that's a positive Lockman. And that's really the main way you're gonna do that. A little bit of flexion, have one hand kind of cradling the femur, the other hand on the tibia, and moving from anterior to posterior. You can have a pseudo-Lockman exam where if you have someone who is sitting initially posterior subluxed, and then they come to a neutral position, that can give you that sense of, wow, this is an ACL. That's really a PCL tear, because they start posterior subluxed and then you bring them back to neutral. So looking where the step-off is on the anterior condyles and the anterior condyles and the tibia is kind of the baseline that you're gonna start with. In the past, we were doing KT testing and other things, and again, ACL stability is more than just Lockman. It's also a pivot shift. And so this is really an example of that where, hopefully this will play, if you see that give where you're going initially with the knee in extension, you're internally rotating the foot, and then you're bringing them into flexion while providing valgus. If you have that reduction of the tibia on the femur while you do that, that's a positive pivot shift. That's rotatory. That's not just anterior to posterior stability. And so that's more, again, the function of rotation, and that's an important part of ACL function, not just anterior translation. This is hard to do when someone's awake. Most of the time, this is probably going to be hard for you guys to do, but if like you ever have a chance to come in, or somebody who is asleep or can really relax their leg, if you can get them to have that subtle pivot, it's, you know right away that their ACL is not functioning. And this is really a very important test. So, you know, again, I'll have a hand on the tibia. I'll have my other hand above so I can provide or put the patient in some valgus. Begin an extension, and the bottom hand will have internal rotation, and then slowly bring them up into flexion. And if you have a dramatic pop as that patient comes back in, that you'll see, that certainly tells you, number one, ACL is torn, but you have to look at other structures. That is like a pivot clunk. That's a very obvious one. So you have to think at the secondary stabilizers. That person, I look really closely at their posterior horn medial meniscus, because a lot of times that can be involved as well. Questions about that? Hard in an awake person, but a big part of doing this. And somebody who has a chronic ACL, a lot of times you'll get an MRI that says the ACL graft is intact, but it's usually vertical. And so there's, you know, one of the things that I always try to tell the residents is there's an important differentiation between having collagen where an ACL is, as well as having function. And so the function of that may be off, but they may still have a graft that's there, it's just not functioning for that. From a PCL standpoint, again, the PCL again has two bundles. They're named kind of the opposite. So PCL has anterior lateral and posterior medial, where the ACL is the anterior medial and posterior lateral. You guys probably have the same mnemonic. Your PCL is your PAL, so it's the PCL is anterior lateral. Again, it's your main stabilizer to posterior translation. Depending on the bundle is really depending on which one will you'll expect to give you posterior translation stability at both flexion and extension. And again, your anterolateral bundle is bigger, so when I reconstruct these, the anterolateral bundle is usually,
Hi.
hey Stacey. So PCL stability, two bundles, anterolateral bundle is larger than posterior medial, so that will be a larger reconstruction. Some people will just reconstruct your anterolateral if you're going to do a single bundle. For ACL, the double bundle reconstruction debate has kind of, I think, gone by the wayside, and most of us are doing single bundle. For PCL, the PCL has a much bigger insertion on the femur, so it's much harder to reconstruct both of those bundles with one tunnel. The biomechanical data very much supports having two bundles, and so that's why I do double bundle reconstruction for PCLs. But there certainly is many people who are doing single bundle, and for the most part, if you can restore that stability with a single bundle in flexion, then you can help them, but it's not biomechanically as strong, and it puts more strain on that one graft. So I will do double bundle PCL reconstruction. So this is anatomy in the back of the knee. So this is your medial meniscus, lateral meniscus. This is a meniscofemoral ligament here, and then the two bundles, anterolateral and posterior medial. So you can see as you come into extension, you're going to have more tension on your posterior medial bundle, into flexion, interlateral. And this is just kind of, I think, an interesting way to look at how this actually synergistically works. As you come into different flexion angles, you actually do have tension on one and then relaxation on the other. Okay, so I won't belabor that, but somebody spent a lot of time doing some pretty cool cadaveric videos there. But basically, it's a much broader insertion. The anterolateral bundle comes right up against this articular cartilage. So in surgery, that's really where I'm trying to put that tunnel. And then the posterior medial bundle is a little farther off the articular cartilage. But I am trying to reconstruct those two bundles on the femur, and then they come through one tunnel on the tibia. So this is a patient from earlier in the year. That's kind of the view I'm getting at the time of surgery, with a guide wire and then drilling over top of that. A lot of times these patients will have difficulty descending stairs, a lot of instability with that, pain when they have to stop quickly because they feel their tibia shift forward when they aren't able to control that. the way to rehab these are certainly heavy on the quad strengthening. You're trying to prevent posterior instability, so you're trying to bring the tibia forward, which is really the function of your quadriceps to counteract that. And then chronically, there's kind of a classic study that looked at patients who had chronic PCL tears, and they had higher rates of medial compartment and patellofemoral cartilage problems. So over time, that's why we're fixing those, is that they put more strain on their medial and the patellofemoral compartment. At Jersey Shore, we see a ton of it with dashboard injuries. So you can have an isolated PCL, an athlete who falls directly onto their knee with a plantar flexed foot also can get you an isolated PCL. But oftentimes, whether they run in other combinations is important to pick up and certainly to treat. So, posterior translation, again, that bottom video is really looking at your posterior drawer. Knee is at 90 degrees, kind of starting with the knee reduced and then pushing directly back. It's not a hard thing to conceptually understand, but when you see one that's grossly unstable, then that's really what we're trying to fix, and that's obviously very unstable. You can also have the patient do a quadriceps active test, where if you sit on their foot and their tibia sits subluxed posteriorly, you can have them try to push you want to tell them to try to push their foot forward, which is going to activate their quad, and it actively raises their tibia anteriorly. So if they sit and they have a resting tone of being posterior, you can have them use their quad with a stationary foot, and they can bring their tibia forward, and that's again a sign of PCL instability. So that's a more chronic thing, but something that you can evaluate and really show them what their posterior instability is. Again, posterior drawer is really the mainstay of this. These are all dramatic examples where you can really see the condyle staying stationary and then that tibia completely subluxing at the back. And again, that pseudo Lockman is important because you can feel anterior posterior instability, but when you evaluate them, it's not because their ACL is torn, it's really because they start subluxed posteriorly and you're bringing them back to a neutral position. So these are these really big ligament injuries that are a challenge, but also a lot of fun and something that you can really work to get somebody a much more stable knee and give them their life back, because that's not stable, and they really will have a lot of difficulty with any sort of athletics with that type of knee instability. What I really try to do is also add objective data to that. So especially for chronic PCL tears, the MRI usually looks normal. And that's been shown time and time again, is that their ligament looks normal, but when you functionally test them, they have evidence of instability. So adding data to that, I think, is a big part of that. I do that both for collateral ligament injuries as well as for PCL injuries. So this is a kneeling stress x-ray where you can have a bump that you put here, and then this space is open so that you're putting a posterior force only on their tibia, and you're getting a perfect lateral of their femur. And so this jig we have over here, and so if somebody who has a PCL tear, I'll get this and I can evaluate how much posterior translation of their tibia they have. And so you can compare, there's a line basically drawn along the back of the posterior cortex, and you can compare that distance from their uninjured to their injured side. And you can see certainly that this is much farther back posteriorly than this. And so this is an injury that, although it may look normal in the MRI, functionally is very unstable for that patient. Any question about cruciate, ACL, PCL? Okay. MCL injuries, again, there's a lot of structures in the medial side of your knee. Really, your MCL is made up of both a deep as well as a superficial MCL. The superficial MCL attaches very distal on the tibia, so it's about 6 centimeters distal to the joint line. Deep MCL attaches more proximally. So, for example, when we're doing joint replacements, when Will's doing a joint replacement, he's detaching the deep MCL proximally, but he won't do his release on the inside of the knee farther than about 4 or 5 centimeters because he's leaving that superficial MCL intact. So that's the way we can get exposure to do a knee replacement, but not destabilize the knee so that they can walk day one and that they don't have a problem with that. And so this, if you look at your MCL and it comes all the way down, the reason that you can do a knee replacement or other surgery like that is your superficial attaches very distal to the joint, so it's about 6 centimeters. Again, it provides valgus stability, both at 0 and 30 degrees of flexion. Certainly if you have instability at 0 degrees, you have to think about not just MCL, but also your POL, your posterior oblique ligament, as being part of your injury pattern. You can also have attachments to the meniscus from your MCL, and so a lot of times when you see someone who has extrusion from a meniscus tear, their meniscus will come and still have attachments to their MCL. It can be part of why they sit off of the tibia. The other thing is when they have, and you test their valgus for a meniscus tear, you are stressing your MCL, and a lot of times that can bother someone with a medial meniscus, and that reason is because it's attached to your MCL. So when you're tensioning that, you are tensioning your meniscus, which is part of their pain generator if they have a meniscus tear. Again, your posterior oblique ligament is an important stabilizer, really near full extension. It's kind of been debated whether it's really a ligament or a thickening of the capsule. Whatever you want to go through, and it's kind of not an important part of this talk, it is something that if you have gapping and full extension, you have to reconstruct that or have to think about having that. Gapping and full extension is a problem, so that's something that usually is signifying a much bigger injury. So, this is a video looking at your medial side of the knee. Again, you can see the superficial MCL, how distal it attaches from your knee joint, your MPFL, and one of the things I want you to watch as this goes into flexion is your MPFL is really just a check rein in extension. So it should be taut in extension to help keep your kneecap centered and in the groove. But as you go into flexion, see how much laxity of your MPFL you have? That's completely normal. So having a tight MPFL in flexion is how many people, if their tunnel is off, can have difficulties getting full flexion after that reconstruction. So that MPFL should be taut in extension, maybe 20, 30 degrees, but then after that it should be very loose. And that's normal anatomy for that MPFL. Okay. So again, usually a valgus type mechanism, this Blake Griffin here had an MCL injury, oftentimes planted foot or a foot that is immobile, and then they have some sort of valgus type force to their knee. Very common in football where somebody's on their foot but they get landed on. This is really the only thing that you see all the linemen wearing braces, and this is probably something you guys get taught as well. This is the only thing a brace has ever been shown to help prevent is an MCL injury in college football. Some people will debate that literature because it's not a very big study with a lot of athletes, but you'll see most offensive linemen who are going to be wearing this as they get to high levels of football, and that's really for an MCL prevention, not an ACL. Most of these can have an infusion. Most of them do very well with non-operative management. The thing, it's been shown, getting them on a bike early helps reorient the fibers, and these are all things an MCL injury is pretty common, but giving them a hinge brace, getting them moving, not putting them on crutches for weeks and weeks and weeks, getting them weight bearing, getting them on a bike, helping those fibers to reorient where they're healing, usually actually does a nice job of getting them both pain relief as well as stability back to their knee. Again, examining them, I'll test both in full extension. A lot of times I'll have my hands on their joint line to feel for gapping and then check valgus, start at neutral and put a valgus stress on that. And you're kind of both subjectively feeling that joint line and feeling for gapping and comparing that to the contralateral side, as well as objectively using x-rays to check for instability. The dial test is also part of evaluating cruciate ligament instability. So if you have a dial test, which this is not normal, you can see if you have an increase of 10 or 15 degrees of external rotation in extension. So this is valgus gapping for MCL. And then if I can get the video to come back. Sorry, this is the... There. So if you have at 90 degrees, if you have increased external rotation, you're going to have and be more concerned about a combined PCL and posterior coronary injury. If it's just at 30 degrees, oftentimes it would just be one. But those are, it's kind of, again, something for a sleep patient that you'll get a better exam, but something that we'll check as we're doing an exam under anesthesia. And these are the valgus stress x-rays that I talked about. So again, in a chronic setting, having an objective finding that can give objectivity to a subjective exam, I think is a helpful thing. So this is another thing I'll do over here, just having them at about 20 or 30 degrees of flexion, getting a stress x-ray in the office. You can objectively say and there's numbers that can guide you through that, you have an abnormal amount of instability to your medial side. And it's a way to put objective data on something that is inherently subjective. So, you can, again, there's data to tell you exactly how much for a complete tear versus a whole medial sided injury. And then you can compare both pre-op and post-op. So usually around 6 months, I'll get follow-up stress x-rays to see and basically check how you did. And patients tend to like a lot, say, okay, it's subjective, but I have objective data to say this is what's exactly fixed, and I'm similar to the contralateral side. And then looking at now transitioning to the lateral side, I think this is something that we didn't understand and was very much kind of the dark side of the knee for a long time. The anatomy, and this is really one of the main reasons why I wanted to go out to Colorado, is that this was kind of the passion of the guy that I trained with, to understand the lateral side of the knee, not miss them, and be able to reconstruct them anatomically. So there's 3 main parts of the lateral side of your knee. Your lateral collateral ligament, or your FCL here, your popliteus tendon, which acts both as a tendon dynamically as well as a ligament statically. So some people will call that the 5th ligament of the knee, as well as your PFL, your popliteofibular ligament. This is a little more nuanced and something that you're not going to really be able to examine well in the office, but understanding certainly your LCL and your popliteus is I think really important. And these are bad injuries. These are usually hyperextension injuries or varus injuries. Certainly knee dislocations have a high propensity to have a posterolateral cord injury. Your perineal nerve runs right about 2 centimeters distal to your the neck of the fibula from the top of your fibular head, and so it's a high incidence of nerve injuries, and certainly something that we look at when we're evaluating patients like that a lot. And just to give you a little view of the anatomy, so again, your LCL here attaches about 18.5 centimeters down, 26.5 centimeters down on your fibular head, and the distance between these two, between your FCL and your popliteus, is around 18 millimeters, and we use that to reconstruct these, so we do it in an anatomic way. I would say the main difference from doing this historically to how I try to do it is if we can reconstruct the ligaments anatomically, put them in the right spot, we don't have to immobilize these people for a month or 2 months. We can range them day 1 because we're not worried about stretching them out. And I don't know if you guys saw these reconstructions, but this was kind of before my time of practicing, but historically we put these people in a cast or a splint and said don't do anything for 4 weeks or 6 weeks. And the problem is that not many of them regained full normal activity and strength because they got stiff. So if we put and we reconstruct their ligaments where they should be, if we tension them in the right way, we can move them day 1. And that's the basis of why and how I try to do a lot of this. And I don't know if you guys saw a lot of these, but immobilizing them for a month or 6 weeks is tough because then you just get stiff. And part of it is you want stiffness, but you want stability, not stiffness. And I think there's an important difference from that. History, you'll have, certainly instability. They'll feel more side-to-side pivoting or planting type things. They can have pain on the contralateral side. So if they have gapping laterally, they're going to have compression medially. They can have medial compartment issues. And certainly a history of a failed ACL, these are things that you have to look for. Again, one of the things I'll check is an increased recurvatum or hyperextension of the knee. And it's a pretty simple test, but it's actually a really good way to pick up and have a higher index of suspicion for a posterolateral corner injury. And that's been written up and has a difference of if it's more than 3 centimeters, you have to think about this. Again, this is how I'll reconstruct it with a big hockey stick type incision on the outside of the knee to identify the perineal nerve, move it out of the way, and then reconstruct the ligaments and the 2 tunnels in the femur, as well as a tunnel in the fibular head, as well as a tunnel on the tibia. Perineal nerve findings and exam beforehand is very important, so getting sensation of the dorsum of their foot, making sure they have intact dorsiflexion, all very important part of evaluating that patient. And if this would play. similar to the medial side, putting your fingers on the joint line, getting varus stress to check for gapping, and having your fingers right there on the joint line. That's like a little pearl to really be able to feel how much gapping is there, and then comparing that to the other side. I'm not sure why some of these videos play and some don't. More of the same there. Chronically, and this is something you may pick up, they can have a varus thrust gait. So if you see them walking and they have this pretty obvious kind of, it's subtle, but you'll see their lateral side open until their bony anatomy kicks in, and then they walk. And this is a very common thing for a chronic missed posterior lateral corner injury, is they have that varus gait. I had a thought, I just lost it. But that's also, you'll see I have a lot of patients walk in the office, and I'm looking for little things like this that will give me an idea of what's going on chronically with the structures of their knee. Again, objectivity I think is very helpful. I'll try to get stress x-rays when I'm evaluating these patients in the office. Anything more than 2.5 centimeters, has been shown to have a tear of that FCO. And over 4 is a complete posterolateral corner tear. So it gives good objective data, especially for a failed ACL or other ligament reconstruction that doesn't work. Doing the same thing over and over again without actually identifying what else may be going on and putting more strain on your ACL is just repeating the same thing and just doing that patient to having probably the same thing just another year down the road. And then final, much less common but certainly real, is tib-fib joint instability. And this is really uncommon, but it's out there, and having an unstable tib-fib joint is certainly something that patients can have, this mechanical popping type symptom on the outside of their knee. Usually it's more in deep flexion. Often they can irritate their perineal nerve, which kind of, again, comes right around your fibular head. And this is something I do think that taping is very helpful. So both kind of deciding on where they think that they're unstable, but usually taping from posterior to anterior, trying to help add stability, is something I would do before ever fusing this joint, because either fusion or reconstruction of these ligaments, it's definitely not something that is number one, a very commonly performed surgery, and the outcomes are a little bit less than ideal. So it's got to be the right indication, the right person. And usually they have to have a very good relief with taping for me to even think about that type of a surgery. Another thing that you can see, if this will play, is a snapping biceps. This is subtle, but you can kind of see this guy's biceps. Watch right here. So the biceps femoris, one of the hamstring tendons attaching to the lateral, the outside of the fibular head. You can see on the outside, you can see that snapping as your biceps rolls over your fibular head with deep squatting. So watch right there. And so again, these patients, they hate life, because every time they step, they squat, they go up and down steps, they feel this, and it irritates the heck out of their perineal nerve. So something to pick up. And so again, physical exam is the mainstay. This is not something you're going to see on an MRI, anything like that. You may see some edema, things like that, but this is a physical exam finding. Meniscus is very common. You guys see a lot of this. Listening to them about mechanical symptoms, I think, is very important. The catching, the locking, having their knee feels like it's stuck and they have to move it in one certain way to get it unstuck. Those are all important things to identify, because for a degenerative meniscus tear, most of the time, in the absence of a mechanical symptom, they can do very well with physical therapy and an injection. If they have a flap of tissue or they have a true mechanical type thing, it's less likely that they're going to get better with physical therapy. And so listening to that is something I really try to do. But it's deep flexion, it's often problem squatting, catching, locking. Those are the mechanical symptoms I try to identify. That joint line assessment, I think, is really important. So both in extension, I'll try to feel especially the posterior part of their knee, so feeling for root tears or other problems in the back in full extension, that can really bother them. So maximal flexion, very common for meniscus tears. Again, they can have pain, and it's important to ask them where it bothers them. If your pain is all patellofemoral joint, anterior knee, when you go into deep flexion, I'm not worried about a posterior meniscus tear. It's more your patellofemoral joint that would make me suspicious of your pain with deep flexion. If you have pain deep in the joint in the back of your knee with deep flexion, then yes, that makes more sense for a meniscus tear in the back of your knee. So not only the test, but where they have pain with that test is important. I think root tears is an important topic that we're learning more about, and certainly is, I think, being talked more about, so you guys will probably start seeing patients who have had these type of repairs before. The root is really the attachment site of your meniscus to the tibia in both the anterior and the posterior horns. I would say it's traditionally underdiagnosed, and part of this is, MRIs are non-weight bearing. They may not show extrusion or problems with this, and if you miss it on the cut, then you may not see that tear. But at the time of surgery, seeing that that meniscus is not attached to the bone, which looks like this, if you have this kind of blinded, blunted end of the meniscus, you should be seeing a confluent meniscus that attaches down to bone. This is a really obvious root tear, and this is a problem because functionally, that acts similar to a total meniscectomy. So the whole point of your meniscus is to distribute axial force circumferentially. And if you can't have attached meniscus both in the front and the back of your knee, then your meniscus just pushes out and doesn't actually protect the cartilage that it's meant to protect. And this is why these patients tend to have pretty debilitating symptoms, and also they can have rapid progression of arthritis. The challenge, and this has been looked at in the total knee literature, is that much of this is part of the degenerative spectrum of meniscus tears. So a lot of times this is your active 55 or 60-year-old who squats down and feels a pop in the back of their knee, and then they're the ones who, I don't know why my knee just went from normal to needing a knee replacement in 2.5 years. And this is a lot of times what the joint replacement surgeon is finding at the time of that surgery. So treating this is important to do it before the horse is out of the barn. If they have bad arthritis, I can't turn back the clock on that. A lot of times this is who presents with that, what we typically would call spontaneous osteonecrosis of the knee, where they have this sunk or very big, bright, lit up medial condyle. Oftentimes it's a root tear in the back of the knee. And for a while we thought it was this idiopathic condition that middle-aged patients were getting with this big amount of edema, their condyle. It was some sort of stress fracture, insufficiency fracture. Many times it's this in the back of the knee. And if you fix that, it can help them. And certainly that's something that you can do in a couple different ways, but most of us will drill tunnels here in the back of the tibia, and we'll pull that meniscus down back to its attachment site with sutures so that it will heal in that position. This is usually non-weight bearing for 6 weeks, working on motion and then building strength kind of after that. So, the summary is getting a good history on a patient, listening to where they have symptoms, what their symptoms are, listening for instability versus pain type symptoms. All of that's like the baseline of this. And then having a thorough exam where you go through the same steps every time, you repeat them, and then use that so you don't miss things is, I think, the important part of this. I think a good exam is worth its weight in gold. I think a lot of times, when you get busy and you have a lot going on, you can try to just go right to it, but a lot of times you have to match exam with their imaging finding and their history, because it's the same principle of, this is so common in spine where you have somebody who has left-sided pain, but then they have a right-sided finding on their MRI. Going to surgery for that right-sided disc is not going to help that patient. The same is true for someone who has, discordant pain with findings on their MRI of their knee. If they don't have something that matches up, you have to be the detective to look into that and not just say, well, you have a tear in your MRI report, I'm taking you to surgery. You have to add it all up, because those are people who ultimately may not get better with surgery, and then it's a much more of a difficult thing to deal with from that standpoint. So, and then I think the only other thing I try to add is adding objective data. I think it's a good way to look at your results as well as to objectively say, look, this is what I believe is going on, and take some of the subjectivity out of the exam, which is an inherent part of it, but when you can add more information, I think it's really helpful. So that was really it, guys. Pretty quick and simple. Alex, what did you think?